Jeff.
Welcome. I'm Jeff Resnick, Senior Historian here at the National Library of Medicine. Thank you for joining us for today's National Library of Medicine History Talk. NLM History Talks promote awareness and use of NLM and related historical collections for research, education, and public service in biomedicine, the social sciences, and the humanities. NLM History Talks also support the commitment of the NLM to recognize the diversity of its collections, which span 11 centuries, encompass a range of digital and physical formats, and originate from nearly every part of the globe. Moreover, NLM History Talks foreground the voices of people of color, women, and individuals of a variety of cultural and disciplinary backgrounds who value these collections and use them to advance their research, their teaching, and their learning. So welcome, everyone. For those of you who wish to share your questions with our speaker this afternoon, please look for and use the live feedback button that you see under the NIH VideoCast. Today, I have the great pleasure and privilege of introducing Dr. Namhee Lee, who is a research professor at the Ewha Institute of History of Ewha Women's University in South Korea, where she teaches various aspects of American history to undergraduate students and socioeconomic and history theory to graduate students. Previously, Dr. Lee was a postdoctoral fellow at her institution and an instructor at Sumyuk Women's University and Hansung University in South Korea, and also at Anju University in South Korea. She completed her PhD in history at Syracuse University with her dissertation entitled The Spock Paradox, Permissiveness, Control, and Dr. Spock's Advice for a New Psychology of Parenting for Democracy in the Mid-20th Century United States. Dr. Lee is author of numerous scholarly articles, two most recently in the Korean Journal of the Social History of Medicine and Health, entitled Toward the Community-Based Prevention, Robert H. Felix and the National Mental Health Act, and The Dream of the New Psychiatry, William C. Menninger and Psychoanalysis. Dr. Lee has also published her research in the Korean Journal of American History, Women in History, and the Western History Review. Today, Dr. Lee joins us from South Korea to share aspects of her current research on mental well-being in mid-20th century America, focusing on the work of Robert H. Felix, the first director of the National Institute of Mental Health here at the National Institutes of Health. And in her research, she's been drawing on the NLM's collection of Dr. Felix's papers. So Dr. Lee, a warm welcome to you, and thank you so much for joining us from South Korea. Over to you.
Thank you, Jeff. Thank you for letting me have this opportunity to present my study. It is a privilege and honor for me to do so. I would like to begin. Oh, there you go. I'd like to begin by reflecting on the remark which Francis J. Braceland, MD, wrote in the American Journal of Psychiatry in July 1961. In his introduction of Robert Hannah Felix, 89th president, 1960 to 1961, a biographical sketch, Braceland described Felix as such. As we survey this rather breathless but wonderfully productive career, in which a dedicated man carried a lamp of sane benevolence, chiefly for the weaker by the wall, we can say to him and of him. This remark allows us to assume that the path Dr. Felix went through might be different from other psychiatrists, since prominent figures in psychiatry and the discipline itself began to acquire fame during that time. Today, I would like to draw attention to Dr. Felix's effort in establishing the post-war direction of public mental health. Before moving on to how Dr. Felix contributed to the national mental health sector, I want to introduce overall information about Felix, who had a long career in the Public Health Service, PHS. Although there is no published biographical monograph or independent research on Felix, his name always appears in the establishment of the National Institute of Mental Health and mental health-related topics after World War II. In a study of sociologist Andrew Skoll, for example, Felix appears without fail in dealing with national mental health, funding from research institutes, and drug-related developments. Dr. Felix was a psychiatrist, as it says, a medical doctor and administrator, and widely known as the first director of the National Institute of Mental Health, NIMH, from 1949 to 1964. He was a former president of the American Psychiatric Association in 1960 to 1961, and was one of the key players to develop an overall picture of the post-World War II mental health policy, who made the National Mental Health Act of 1946 possible. Born in 1904, Downs, Kansas, to rural Dr. T.O. Felix and Neva Felix, he pursued a career in mental health rather than in psychiatry. After earning his doctoral in medicine from the University of Colorado School of Medicine in 1930, he completed his internship at Colorado General Hospital and worked as a resident at Colorado Psychopathic Hospital. He began his career in 1933 at the US PHS and maintained various positions at the PHS during the Second World War. As an officer of the PHS, from 1936, he was assigned to the Federal Narcotic Treatment Center in Lexington, Kentucky, after serving for 3 years at the PHS Medical Center for Federal Prisoners in Springfield, Missouri, under the Department of Justice. He received his master's degree from Johns Hopkins University, School of Public Health in 1942, and was deployed to the Coast Guard Academy as a psychiatrist and senior medical officer. He returned to the PHS in 1944 and worked as an assistant chief of the hospital division at the Bureau of the Medical Service. In the same year, Dr. Felix became the chief of the mental hygiene division. His career development allowed him to be the most experienced officer who understood public mental health policy during the time. Around 1940s, most psychiatric specialists had experience with state hospitals or running private clinics. In contrast, Felix, because of his career and experiences at a couple of agencies under the PHS, was one of those who knew better than anyone else the need to improve the existing mental health care system, which would determine the big framework for policy direction after World War II. Also, the fact that he was out of the post-war methodological debate on psychoanalytic approach in psychiatry seems to have played a major role in his unrivaled position. Known as the first president of the National Institute of Mental Health and a central figure in passing the National Mental Health Act of 1946, Felix is not a widely known figure compared to his fame of his time. Despite playing an important role in determining American mental health policy in the mid-20th century, information about him is still limited compared to other medical professionals who worked around the same time. Fortunately, I was able to have an opportunity to research the Robert H. Felix papers at the National Library of Medicine in summer 2022. This talk is part of the study based on the fieldwork for the Felix papers. These note to some extent that World War II served as a symbolic opportunity for the development of both American psychiatry and national mental health. And it would be useful to take a closer look at the direction of development by tracing Dr. Felix and accomplishments and contributions. Also, an understanding of the direction and initial goal of the federal mental health policy would illuminate the origin and complicated reality of post-war national mental health policy. So when we deal with change or development, oftentimes overcoming the adverse circumstances of the past and improving in a better way is the ideal description. And the period when I covered here was also recognized as a period of modern development of psychiatry, or a period of change, especially World War II. Gave unprecedented clinical experience because of the number of patient soldiers who suffered from neuropsychiatric symptoms. These completely different experiences and lessons from the war emphasize the limitations of the state mental hospital system, which had been maintained until 1940. However, these dramatic elements also have the effect of making the previously weak and existing efforts look like just failed attempts. So before dealing with the details of Felix's ideas, I want to talk about the reality of mental health care in the early 20th century first. As previously known, the reality of psychiatric institutions at the beginning of the 20th century did not seem ideal. In particular, the mental health situation just before World War II seemed to be worse than that of other medical departments that advocated scientific medicine. Although World War II and subsequent changes seem to have had a significant impact on psychiatry's transformation into a discipline that plays a major role in federal health policy, the war itself was also the main culprit that made the situation of wartime mental health much worse. Under the wartime mobilization system, psychiatrists who originally were not plenty of had to go to the battlefield. And this was not limited to doctors. Almost all nurses and other staff who were directly or indirectly engaged in the state mental hospital system had to move to work for the country in a critical national crisis. As a result, the number of doctors and medical workers compared to patients decreased even more. And it was relatively difficult to maintain the status quo in domestic mental health because funds were invested in conducting war in all directions. However, the poor mental health situation had already begun in the early 20th century. The biggest problem was that the turnover rate of patients admitted to state mental hospitals had dropped significantly. There has been a prejudice that psychosis was an incurable disease, but rather by the end of the 19th century, most inpatients were discharged within a year. Of course, these statistics were not indicators of the superiority or effectiveness of the pre-20th century mental hospital system. Patients suffering from chronic diseases who were not able to be treated within a year were sent to another shelter institutions. However, since the 1890s, the length of hospitalization for state mental hospital patients had steadily increased. And in the 1920s, long-term hospitalizations for more than 5 years accounted for more than 50%. This change was accompanied by measures taken by the state policy. The clear line between the local community responsible for chronic patients and the state government in charge of treating acute patients and building state institutions had been blurred since the end of the 19th century. State psychiatric hospitals treatment appeared to be effective in mental illness management, but facilities under local community appeared to be inefficient and poor institutions filled with chronically ill patients. State officials therefore determined that state-affiliated hospitals admit people who could be classified as mentally ill. The thing is that the chronic condition of the patients was not the result of their confinement in community institutions. Rather, most of them could receive family help in the first place, could not receive. And local governments did not miss a golden opportunity to save budget. Local government officials identified various mental defects and degradation caused by senility as mental illnesses. By 1940, for instance, 31% of new patients were admitted to mental hospitals under the state of New York, and by 1950, 40% were over the age of 60. State mental hospitals, which had mainly dealt with short-term and extreme symptoms, became institutions responsible for chronic patients with physical illness, especially older patients, since 1920s. And these institutions often had to take care of them until death. Confidence in effective treatment and successful overcoming gradually disappeared. And state mental hospitals became simply places where aging and helpless patients must stay until they die. And for patients who had various mental symptoms due to aging or physical illness, what a psychiatrist could do was relieve or stabilize temporary symptoms. Treatment of the disease became increasingly scarce, and casual care was the main task for them. And this change was not just a problem for state mental hospitals. The successful treatment experience was an important factor in maintaining medical discipline. But the fact that prescribing long-term inpatients drugs or monitoring became the main task had no choice but to negatively affect psychiatry as medical discipline itself. In addition to the poor working conditions, the inability to feel rewarded as a profession made psychiatry even more unattractive. And the clinical experience that is most essential for the development of medicine became limited to certain age groups and specific diseases. The experience of treating patients with new symptoms is risky but essential, but state mental hospitals were no longer able to play this role. However, it is interesting to note that mental hospitals' internal conditions were relatively better than other state shelters and institutions in the late 1920s, when the aftermath of the Great Depression began. Hospitalization treatment was better than community or individual treatment in terms of nutritional and living conditions. The number of elderly patients who could not be cared for at home increased in the aftermath of the economic crisis. Maintaining the status quo alone might have seemed like a better condition than elsewhere at the time, but that does not solve the mental hospital itself, which had been revealed since the 1920s. Time passed without changing the reality of increasing patients' numbers, reduced finances, and aging facilities. Compared to the 1930s, in the 1940s, the existing problems became more evident. Already, the increase in number of patients with chronic diseases meant an increase in the density of the receiving population. In the 1930s, even institutions that received stable financial supply and demand would have been able to maintain the status quo. So it was difficult to expect to improve the environment of patients. The biggest problem was that the number of medical professionals was decreasing nationwide due to the participation in World War II. The number of patients per capita increased, of course, and the high population density acted as tremendous psychological pressure on inpatients. The situation of care worsened as the number of employees also gradually decreased. In addition, financial difficulties made it impossible to build new facilities to accommodate a growing number of patients. World War II, which served as an opportunity for the development of psychiatric division, had a negative effect on the existing state mental hospital system. It is well known that World War II was a symbolic turning point, as I mentioned before, for the development of psychiatry in the United States. The image of the disease previously dealt with by psychiatry was treated as far from modern science, which advocated scientific approach, until the moment the United States decided to participate in the war due to the attack on Pearl Harbor. Psychiatry was still for an individual's mental illness and mental state. Since the end of the 19th century, many theories had emerged due to psychoanalysis or the development of psychological methodologies, but were rejected by the American psychiatry community because those theories had a European tradition or seemed unscientific for them. From the mid to late 19th century, state mental hospitals were by no means an underdeveloped accommodation facility. About 50% of patients with acute mental illness in the mid-19th century, as I mentioned before, had been hospitalized for less than a year. Until 1880, the number of patients with chronic diseases remained at 5 to 10%. This short hospitalization period determined the capacity of mental hospitals. And it can be said that psychiatric departments centered on psychiatric hospitals before the 20th century experienced relative success compared to the 20th century. At that time, isolation into the institution, which involved separation and care in the existing environment, was recognized as the best treatment for acute diseases. However, this belief led to the environmental degradation of state mental hospitals from the late 19th century to the early mid-20th century. And this deterioration of the environment led to efforts to improve the environment in mental hospitals. The beginning of the mental health movement, which can be seen as the origin of mental health policies, was the publication of Clifford W. Beers's autobiography in 1908, which was a mind that found itself very famous one, and the establishment of the National Committee for Mental Hygiene in 1909. Starting with this, the scope of the mental health movement gradually expanded to areas that were thought to be related to mental health at the time. As the importance of the environment, including the relationship with caregivers' experience in the process of growth, was highlighted in the human mind, it was thought that the environment should be improved to prevent the deterioration of mental illness in advance. Therefore, interest in intellectual disability since the 1920s in accusations of poor conditions in state mental hospitals in the 1930s were made. In addition, this mental aspect began to be emphasized in a quarantine of immigrants and foreigners, which was also an area that PHS oversaw. Interest in school-aged children also expanded to areas related to mental problems, such as dependence, juvenile delinquency, and other problems. And the area where the role of the federal government was prominent was related to drug addiction. The enactment of the Harrison Narcotic Act of 1914 made it possible to punish doctors who had the authority to prescribe drugs. However, I realized that drug addiction was not an area where only punishment was cured. Although it was necessary to apply a certain period of isolation, it was not easy to understand the direction of the mental hygiene movement at the time and the addiction or dependence of the time. So the response to this failed. However, this provided an opportunity for drug addiction to be accepted as a medical problem, not just a problem that was solved by criminalization. In 1930, the PHS renamed the Narcotic Division to the Division of Mental Hygiene and expanded the role of federal government. The Division of Mental Hygiene expanded its role to manage narcotic farms, research on the nature and treatment methods of drug addiction and rehabilitation of addicts, spread information about treatment and research, work with the state and community in maintaining facilities for the treatment and care of addicts, and prepared medical and psychiatric treatments in federal prisons. It also played a role in investigating the causes of spread of neurosis and psychosis, as well as the methods for prevention and treatment. In 1938, Lawrence Cole, who was known as the authority on drug addiction research and treatment as the head of the Division of Mental Hygiene, came to the fore and served as the Department of Mental Hygiene under the PHS until Felix was appointed as his successor in 1944. However, from 1939, when the devastation of the war hit Europe, the United States had to consider participating in the war. In line with the Roosevelt government's stance of advocating a scientific war, the future war was to say goodbye to non-science, which was unpredictable like the previous war and only dealt with the impending situation. The establishment of the Office of Scientific Research and Development, OSRD, in 1941 was like signaling that the situation during and after World War II would be completely different from before. As I mentioned previously, Felix's history allows us to presume why he was the first director of the National Institute of Mental Health, which would be the spearhead of mental health policy after World War II. Many people in the post-war psychiatry thought that the discipline should play an extended role different from before, but there were divided opinions on its approach and methodology. Starting from World War II, voices calling for expanding the social role of psychiatry were created, centered on the American Psychiatric Association. This debate represented a disagreement between those who were trained in the state psychiatric hospital system before the 1940s and those who were newly deployed during the World War II. However, because the number of doctors who worked before World War II was almost the same as the number of doctors who were put into the war front, the direction of development in psychiatry and mental health depended more on newly trained doctors during the war. Based on their experiences of the war front, they actively try to use psychodynamic theory or psychoanalytic methodology to expand their power, and senior medical staff who were familiar with the existing psychiatric hospital system were against this trend. However, by numbers, about half of the association's APA's members seem to have agreed to expand the psychiatric department and expand their influence, and about a quarter of the members strongly expressed antipathy to this. William C. Manager, who rose to the highest rank among psychiatrists who fought during World War II, representatively led this change. He was an avid supporter of psychodynamic theory and wanted to make the most of it to expand the authority of the branch of psychiatry by achieving popularity and professionalism together. Felix, however, remained somewhat distant from the association's debates. When the APA began debating what role they should play after the war, Felix had already planned, under the leadership of Lawrence Kolb, his mentor, a blueprint of federal mental health. He was preparing once again for a legislative process for the National Mental Health Act at the federal level, which failed once before. The Division of Mental Hygiene, which was created in 1930 under the influence of the mental hygiene movement in the early 20th century, was of an unprecedented scale at the time, but it was primarily responsible for just drug addiction. They were just focused on that. However, in 1936, the Mental Hospital Survey Committee was launched in cooperation with the National Mental Hygiene Commission, the APA, and other major medical associations. This was because they were aware of the poor environment of mental hospitals at the time, and there was some consensus that there should be federal action to improve the situation. In particular, Kolb. I'm also now studying his papers as well. It's online actually in LMM. Thought that institutions for basic research, such as the National Cancer Institute, established in 1937, were absolutely necessary to improve mental health. Kolb planned to conduct more organized research and established a National Neuropsychiatric Institute to fund strategic areas, but it was not realized due to the outbreak of World War II. Felix's role in enacting mental health laws shortly after the war can be understood as an extension of the public health department's consistent efforts. In a 1943 study, an integrated medicine psychological program at the U.S. Coast Guard Academy, where he was serving, 4 authors, including Felix, measured whether success failure in performing their duties as an officer was predictable through a variety of methods, including personality tests, competence tests, in-depth personal interviews with experts, personal data surveys, and group psychological tests. And it was concluded that this complex testing method allowed some discrimination between individual competence and the potential for survivor and adaptation in groups. The wartime research revealed what scientific research Felix carried out during World War II at the PHS, and at the same time shows that he was somewhat different from conventional psychiatrists. Many psychiatrists who served as medical officers during World War II often directly observed and dealt with the symptoms of war neurosis, while Felix was conducting scientific research in the Resolve unit to help establish national mental health policies. Felix was struggling with federal mental health policies, whereas most of the medical professionals in other psychiatrists since 1945 had made efforts to improve the status of psychiatry as a more acceptable discipline to mainstream medicine. After World War II, mental health took on a completely different appearance and direction. As historian Gerald Robb noted, the long-lasting paradigm that whoever had a mental illness should go to mental hospital had changed. Although the environment in mental hospitals in the 19th century may still be considered very poor and unpleasant from the perspective of the 21st century, of course. They were institutions that took care of patients with uncontrollable symptoms on behalf of their families or communities. And based on the hospital's records, most of the patients were sent back to their families after spending some time in the hospitals. There was no reason not to send patients with mental illness to these institutions. And even though some institutions suffered from financial problems, a shortage of medical personnel, and deterioration of the environment, the superintendents and staff of the institutions thought that those problems were not unsolvable. They often thought that financial and manpower shortages could be temporary, so that the improvement of the environment was possible accordingly. However, as we've seen, the deteriorating reality of state psychiatric hospitals in the early 20th century and the first-hand experience of neurosis related to environmental factors during World War II further made the existing system inoperable. Patients suffering from neuropsychiatric symptoms, including war neurosis, which emerged or recognized in World War II, could not be accommodated in an environment where treatment efforts were mainly focused on psychosis. Furthermore, there was no way to explain neuropathic symptoms caused by extreme environmental stress using the existing analytical method or family history. In particular, the understanding of environmental factors needed to be broader than the environmental formed in person-to-person relationships that psychoanalysis or psychology claimed in the early 20th century. The new mental health system prepared based on this understanding had to go in completely different direction from the existing system. However, it was not enough to determine the national mental health policy simply by going differently from the existing system. Since the mid-20th century, mental health policies had aimed to create an in-depth academic understanding of the disease. The necessity of a training system for medical personnel based on that understanding, and the creation of an environment completely different from the existing system. Therefore, the National Mental Health Act of 1946 provided research support for the cause, diagnosis, and treatment of psychiatry based on the establishment of a research institute with hospitals and laboratories capable of clinical testing, fostering professionals capable of simultaneously researching and nurturing prospective students, in funding from the state government to expand the mental health foundation of the community. If mental health patterns developed around the operation and maintenance of state mental hospitals by 1940, it became clear that the direction of post-war mental health policies was significantly different. Felix's testimony at the three-day hearings held in September 1945 and March 1946, respectively, represents the views of the PHS. First, the House hearing held immediately after the end of the war emphasized that the health system built during the war was temporary. In particular, he emphasized the need to re-examine the mental health system, which was maintained until 1940, noting that the transition from wartime to peacetime was not limited to veterans. It was an urgent task to determine whether state or community facilities and professional training institutions were prepared to accept new changes. And after these preparations were completed, it was planned to allow medical students to receive basic psychiatric training. This was the first line of defense which meant giving general practitioners information or training that could detect various signs of symptoms. So in addition, citing the statistics of residents in psychiatry in 1944, it was mentioned that hospitals with empty seats for residents training account for 2/3. Starting with filling the vacancy, it was argued that other institutions that can be trained should be increased, and mental health medical personnel should be expanded as soon as possible by entering medical workers through short-term training or low-intensity training under the supervision of professional manpower. As the Senate hearing, Felix submitted a prepared document and attached in person to continue watching the overall situation. Already, voices of great opposition to the urgency and necessity of enacting the National Mental Health Act were not gaining strength, but Felix remained cautious until the end. And in the pre-written opinion, specific action plans and blueprints were well contained. It emphasized the urgent need to first solve the manpower shortage when federal funding is provided. Since training experts was not possible in a short time, it had to proceed quickly. In particular, expanding manpower was an essential prerequisite to achieve the transition to the community setting of defenses or mental health. He mentioned that the number of facilities and faculty members should be increased in existing medical schools, and additional training centers, including hospitals and medical schools and other educational institutions, should be increased if necessary. At the same time, he emphasized that the standards for establishing educational institutions had already been established, so it can be implemented immediately. He thought it was useless to set up clinics and increase mental hospitals without adequate manpower expansion. So I think it was kind of like step-by-step process for him. So it would have been possible to expand the field of psychiatric research if more psychiatrists could be trained. Felix pointed out that the identification of the causes of mental illness up to that point was poor, and thought that research to examine the innate characteristics and causes of various types of mental illness should be conducted first. The study was also conducted to explore the functional types of mental disorders, how nutrition and diet correlated with mental illness, mechanisms of the autonomic nervous system, various one, and condition reflection, functions of various brain regions, and electric movement in the brain. In addition, it was thought that the effects of various ecological factors that cause the development of abnormal conditions must be understood from the perspective of the dynamics of mental illness. Through this, he argued that case discovery techniques that can be applied to many people should be developed. The direction of this study was ultimately one of the essential basic tasks for community health. In particular, identifying how the disease itself develops, and rather than develops in an individual specific situation, was essential to the health promotion plan for the group. In addition, finding out the mechanism of the disease was only possible when it was possible to specify the initial stage and determine what measures were possible. The plan to interfere with the progression of the disease as much as possible through prevention and initial intervention was an urgent prerequisite for the transition to community healthcare. And it can be difficult to estimate that clinics or hospitals established in the community will be able to function properly only after these things become possible. It presented a blueprint for expanding outpatient clinics in the community to act as outposts that can intervene in any way in the early stages of mental illness. Community clinics must be easily accessible to anyone, and inpatients were also considered to manage them after early discharge if follow-up treatment services through the clinic were possible. This was also a way to improve the efficiency of mental hospitals, which had considerable finances at the time. Oh, not yet. To conclude, Dr. Felix's effort on national mental health represents an ambivalent aspect of motive control in post-war America to me. Looking at the establishment and operation of NIMH from 1949, we can see that the goal of the federal policy was to penetrate everyday life in all directions. This new direction of mental health policy after World War II shifted the central point of health control to a way that is invisible but ubiquitous by choosing to closely infiltrate communities. In other words, unlike the existing control method, it was rather a way to prevent the mental health of the country from developing the disease and defend against minor symptoms through daily spread. Interestingly, from my point of view, which is more accustomed to authoritarian systems of the state, I don't know if this is correct, but this all encompassing infiltration into the community meant decentralized control with centralized federal funding. Thank you very much. This is it. Yeah.
Dr. Lee, thank you very much for your talk. Fascinating. Several questions we've received, and I'd like to begin with a very broad one. So many have written in to thank you for your talk, of course. This broader question is, to what extent, if at all, did the assessment of environmental factors, as you described, reflect the beginnings of what we call today the social determinants of health? Any thoughts about that?
Well, environmental, I guess I'm kind of struggling the concept of this one now, because I think I might just generate my memory, I think, environmental, because I think it's early 20th century, or maybe some sort of Freudian era, 1920s and 30s in the US. Environment itself actually meant that some sort of like the ego development or the character development, while or just dealing with their some sort of the self-development. So it was more like a first caregiver and me. They are kind of interacting with each other. Through that process, someone actually was shaped, or someone's character was shaped through that process. So I guess very initial stage of the psychoanalytic thought, the environment was more like a object relation theory, like that was kind of part of my some sort of formation of the character. That was the environment, like your family, your some sort of the book that you read, something like that. But then I think after World War II, the environmental factor was more like expanded to some sort of, external stress or extreme anxieties at the same time. They felt some sort of very different experience. They felt and they experienced there some sort of very extreme feelings of something. So I thought it was, I need to have more kind of clear classification or maybe definition of the environment. But I now just briefly, I could draw the line between those environmental or environment, the concept of the environment.
Sure. No, and you've done an excellent job in that regard, the trajectory from the internal to the external, as you said. So
Yes.
thank you.
Yes.
Yeah,
Right.
that's very good. Thank you. Thank you. Appreciate the question. Someone else writes in, thank you for your research into Dr. Felix and the U.S. mental health policies. And the question is, was there any formal evaluation of the effectiveness of incorporating psychiatric training into medical school curricula? When doctors who went into practice in other areas of medicine had this background in psychiatry, did it improve their ability to identify and refer patients to mental health specialists?
Well, that's a difficult question for me
Sure.
because I mean, as a historian, not a doctor, so I'm not really sure about that. But I think during the World War II, as I know, there are a bunch of physicians who just train some sort of psychiatric like residents or something like that, or special education like for maybe 2 to 3 weeks or just a month. Then they just got into the war front or some sort of I don't know, the armies and things like that. So they probably just could recognize the symptoms or external, I don't know how to say, some sort of symptoms and signalings. So that's what they did actually during the World War II. So Dr. Felix, including other psychiatrists, they felt that they were not prepared for that sort of situation. Like so many people suffered from like neurotic symptoms, and then, but at the same time, neurotic symptoms were visible, fortunately. So I thought it was they were probably could guess, and also with their training they could tell something, but I don't think it's proper training to be real psychiatrist, I think, during the time. But I don't know, being a real specialist or the medical profession, I just assume, or just it was just my guess to understand.
Yeah, thank you. How did you become? Sort of limitation. Yes, I'm sorry.
No, that's fine. Just go ahead.
How did you become interested in Felix and the broader subject of mental health in America?
All right. As you know, my doctorate dissertation was about pediatrician, the most famous, Benjamin Spock, right? So I naturally got into some sort of discipline of medicine. And also I was more interested in the concept of something. I was really pleased to have that first question, the concept of environment, and then the definition of that. I'm always into that kind of concept. And then I got into the concept of addiction first. And then, as I mentioned, Lawrence Kolb, actually he was a specialist for addiction. And then I was wondering why Dr. Felix Lawrence Kolb was a predecessor of Dr. Felix. So I thought it was what's kind of the connection between drug specialist and psychiatrist. Of course, I mean, Lawrence Kolb was a psychiatrist as well, but then he was a specialist on addiction. And then I was just puzzling that what's kind of the connection between the addiction specialist and the psychiatrist. Of course, psychiatrists at the state hospital, they dealt with the drugs. So probably there were some sort of connections between them or between those profession or even their relation. But then I am digging in Kolb's the concept of addiction and how he put addiction into the realm of psychiatry as well.
Got it.
So
Okay.
how I got into Dr. Felix was that point. I mean,
Mhm.
actually, the connection with Lawrence Kolb was the first step. And then I found Felix's paper. Of course, Kolb's paper is actually online.
Mhm.
So
Right.
I thought it was interesting to see actually both of them
Right.
from PHS. Then I wanted to figure out how the concept of addiction actually developed into the psychiatric terms. And interestingly, it was actually in part of the psychopathic
Mhm.
disorders, actually, in the first edition of the DSM. So
Right.
I
Right.
got into all those interesting things into that.
Very good. Very good. Glad the library could be a resource for you, because we do
Yes,
have both of their papers.
a
Yes.
lot of things to do actually for me.
Yeah.
Yeah.
So a couple more questions. Thank you again for this excellent and informative talk. Could you say more about the budget aspects of mental
Oh,
health institutions in the early 20th century?
mm.
Was state and federal funding available for institutions at the community level? And were there for-profit institutions that took money from families to care for patients? And if so, how did these compare with state-funded facilities? How did the for-profit institutions, if they existed, compare to the state-funded facilities?
Well, I assume that there should be some institutions with um, just a profit from the patient's family,
Mm-hmm.
but I haven't really looked at really deeply or thoroughly with that.
Right.
But in terms of the state institutions, um, interestingly, in the 1920s, they were built. They built some sort of institutions or asylums, or not asylums, but I think it's more like a segregated
Mm-hmm.
colonies or narcotic farms, because they wanted to divide some patients into different parts of the institutions. Because, as I mentioned, up until 1940s, they felt some sort of helplessness
Mm-hmm.
to not to be. I mean, for patients was not really cured. So it was more like helpless feeling to just make a classification of them. And also 1920s, as you might know, it's kind of the era of some sort of, I don't know, I would say the segregation of the um, how do you say that? I just slipped the word. Mm. Oh, intellectual um, disabilities, I guess I would say now. And
Mm-hmm.
then I guess that was kind of feeble-minded people during that time. They call that. Um, uh, they were segregated as well. And then the
Mm-hmm.
state policy was more like they built some sort of institutions or more like a working farm in order for them to work as a citizen, because they were not really handicapped or they were not really with disabilities. They thought that they were more like the people who have been called feeble-minded, they were more like a low intelligence or something like that.
Mm-hmm.
And then a lot of people, I guess maybe elite group in the US, they thought it was more kind of useless to have them in a hospital. And then they wanted to actually make them work so they can send them to another institution. So probably the state funded a lot of money to build those facilities first. And then they wanted to divide it, or even, I guess, for state hospital, mental hospital, they wanted to house or they wanted to have those, like long-term patients. But then it actually goes up to, the budget, they were more like running out of the budget to have all of them until they die. So I guess that's kind of the reason that they wanted to divide some level of patients and then send them to utilize them as workers or laborers in that institution. I thought it was I don't know, like academically interesting to see that as well. That's another one that I'm digging in now.
Thank you. Thank you.
Yeah.
So we have time for one more question. You noted that older people with common age-related mental decline were often institutionalized by their families. Did the managers and leaders of the institutions try to discourage this by rejecting those patients or explaining to the families that their relatives were not mentally ill, just experiencing normal age-related decline?
Yeah. I think I just missed the question.
So what I think this question is getting at is, did the managers and the leaders of the state institutions, those where people were institutionalized, did they try to discourage
you mean to decline them to be institutionalized?
Correct. Yeah.
Well, I guess maybe up until 1940s, they couldn't reject them. I guess because I mean, when they got their patients, probably just stay housed up until they die. Actually, that's kind of the pattern because of that. I mean, custodial care, which means that they didn't have anywhere to go. I guess they probably just, in the beginning of their institutionalization, I guess there is no place to go for them. So inevitably, they were more like permanent inpatients. So that's why I mentioned the superintendents of the institution. They kind of established another one to like institutionalize some sort of like lighter, I would say, or even inpatients with some sort of able-bodied. I guess that's part of this that the situation that they kind of try to make this situation better. I mean, with that senile people or just older people with any possibility to recover. I guess that's the way they didn't really reject, but they did something to solve the problems with the older people, like just, I mean, like using sedative just to be calm. And then I guess that's kind of the situation during the 1940s, but unfortunately, after 1940s, I guess they just moved to the direction, as I mentioned, in the 1940s and 50s. I guess they were moving toward some sort of this community-based, like non-institutionalized psychiatry. So I thought it was kind of the end of up until their life. Probably they didn't get another patients or other patients more, but then I guess up until 1940s they just hadn't rejected. They hadn't rejected. They didn't. But then I would say they used different way of classify those patients. Yeah, I would say that.
Fair enough. Okay, thank you. Well, we've reached the end of our time together, and on behalf of the National Library of Medicine and my colleagues, I'd like to thank you very much, Dr. Lee, for preparing this talk and for coming to our library for your research over the years. We're grateful to see you both virtually and in person. And we wish you much continued success in your future research and eventually publishing your work even more than you have, so we can learn about your work on Dr. Felix and all the related subjects. So I thank you. I wish you well, you and your family in South Korea. And I know it's the middle of the night for you, so we're especially grateful that you took the time to be with us. So have a peaceful rest of the evening, or in this case, early morning, and we will look forward to keeping in touch with you. Thank you.
All right. Thank you.
So before our viewers leave us today, I'd like to remind everybody that we have our very last NLM History Talk coming up in 2 weeks on Thursday, November 21st. We're going to be welcoming Dr. Oge Shuku Williams from the University at Buffalo, who is an associate professor of history there. She is a 2022 NLM DeBakey Fellow, and she's going to be speaking about research that she's completed in the NLM collections. The title of her talk is Assailed at Home, Champions Abroad, the ACNM's Push for Maternal Healthcare Advancements in Nigeria. So please join us on Thursday, November 21st at 2 p.m. Eastern Time. This talk will be live streamed globally via the NLM YouTube channel and NIH VideoCasting. And in that regard, I'd like to thank our colleagues behind the scenes who make the videocast and the YouTube streams possible. So we thank them. And of course, we thank Dr. Namhee Lee for her presentation today. Wonderful research conducted in the National Library of Medicine. So again, we thank her and we thank all of you for tuning in today, and we look forward to seeing you on November 21st for Dr. Williams's talk. Thank you. Have a good day. Bye-bye.